Thank you very much. It's a pleasure and an honor to be participating in this conference and this meeting tonight. And it's good to see old friends on the screen, even if we are 10, 12 hours apart. All right. Well, again, thank you. My apologies for the delay. And again, it's a pleasure and an honor to be participating in this. And this is intracerebral hemorrhage, as was alluded to, has been something that has been an elusive target for managing strokes because of the paucity and lack of acute therapies. Although I'm optimistic that in the near future we will start having more tools to address this catastrophic form of stroke. I'm going to advance my slides. These are my conflicts or disclosures, for lack of better words. So, why do we care? And again, it'd be nice to say that the incidence of hemorrhagic stroke is decreasing, but it's just the opposite. And we're seeing a dramatic increase in not only the number of strokes that are due to intracerebral hemorrhage, but also the proportion of strokes that are due to ICH is going up actually worldwide. And the reason why that's important is several-fold. It tends to disproportionately affect countries that can ill afford this. And secondly, the mortality of this disease remains terrible. It remains, as you'll see here shortly, a very lethal form of stroke that we currently don't have a lot of therapies for. And those that do survive, unfortunately, are left with severe deficits. And so despite not having any scientifically proven treatment for reversing the effects of intracerebral hemorrhage, we do have therapies that can prevent it from becoming worse and hopefully improve the patient's outcomes. So to give you an example of just how lethal this disease happens to be, and again, there are various statistics out there, and I think the one on the bottom right that you can see is very telling, and that in patients who survive their intracerebral hemorrhage, at 12 months after their hemorrhage, the mortality rate is approximately 50%. And that's very sobering and very different than what we see in acute ischemic stroke, where it's much less than this. It does affect populations differently. The image above shows the disproportionate impact that it has on men. And again, the other thing is that it's an extremely costly form of stroke, not only for the patient and their families, but for their particular countries that they live in because of the severe disability that these patients face. When we talk about intracerebral hemorrhage, there are different types, and we'll get into the pathophysiology of ICH and how we classify them as primary or secondary, but oftentimes we describe them based on their location. And so in this graph, you can see that the A area, the lobar hemorrhages, is what we commonly associate with patients who have amyloidosis. Whereas in the slide, you see B, C, and D. These are all areas, the lenticulostriates, the perforators off the basilar artery. These are common locations that we see in patients with long-standing hypertension and due to the damage that hypertension produces to these small vessels. And then we also see them at other locations like the cerebellum. So oftentimes, ICH is described by its location, and the location is equally important in terms of a prognostic and an intervention standpoint. When we talk about ICH, again, we have the primary etiologies, as I alluded to. You have the arterial hypertension, arteriolopathies due to longstanding hypertension. You have the beta amyloid deposition in vessels like you see here with the red arrow. And then we also have the secondary etiologies. They can be vascular malformations like AVMs, AVF, aneurysms. Oftentimes it's associated with therapies that we're providing, such as anticoagulation. It can be related to substance abuse, cocaine in the United States in particular. And again, I just want to mention that not only are these the causes of the ICH, but we also see that these are not a static event. And so it really provides us an opportunity to perhaps mitigate some of these factors that occur after they've occurred. So what are some of the risk factors for spontaneous ICH? And again, I'm not going to be talking about traumatic ICH in this. And so we have the modifiable risk factors, with hypertension being the predominant one, but there are others that we can use to try to address in our populations with our patients in terms of smoking, substance abuse, anticoagulation use and doing it appropriately, alcohol, and then we have the non-modifiable. Clearly, for example, amyloid is rarely, if ever, seen in patients under the age of 60, but then it exponentially increases. There are genetic predispositions. Apolipoprotein E, both alleles 2 and 4, are more commonly associated with amyloid deposition, certain ethnicities, gender. So we have opportunities to try to prevent intracerebral hemorrhage in our patient populations, and then other ways to look at patients and identifying those who are at higher risk to make sure that we are really doing everything possible to limit their potential. I'm going to speak to anticoagulation a couple times during this presentation because it's of particular importance to those, especially like myself, who may see these patients in the emergency department, both in a small hospital or a larger hospital. And the reason for that is several fold. One, we need to know that they're on anticoagulants because the use of anticoagulants and an associated ICH increases their risk of having an ICH, but also increases their mortality by more than twofold. Secondly, that if we don't correct the anticoagulation and the coagulopathy, in this case due to warfarin, we see that these hematomas tend to be bigger in size, they have more interventricular extension, and they also continue to grow over a longer duration. So again, having anticoagulation is an increased risk for having a ICH, and once you've had it, it's an increased risk for morbidity and mortality. So this is something that we have to consider when we see patients with an ICH. The other thing I'll just quickly touch on is that, COVID has obviously been a very disruptive pandemic for the past year, and we've seen COVID infection associated with increased risk of stroke and venous sinus thrombosis. But we've also seen ICH associated with our anticoagulation that we've been providing our COVID patients due to their hypercoagulable state. And so we do see patients that with COVID, and not that the COVID causes the ICH most likely, but it's due to the iatrogenic effect of our treatment of COVID that increases this risk. And as you would assume, that patients who have COVID and develop an ICH have an exceptionally high mortality. So we have to be cognizant that our patients that we're managing with COVID and who may require anticoagulation have a significantly increased risk of having an ICH. So there's various mechanisms by which an intracerebral hemorrhage can cause damage to the tissue. First and foremost, it's a mechanical engineering process, right? We have a mass effect. We have this interparenchymal hematoma volume that causes a mass effect that, with its associated perihematomal edema, presses on structures in the region, decreasing the regional perfusion. It can lead to herniation. It can lead to interventricular extension with hydrocephalus. But also the degradation products for that hemoglobin and the iron that is within that hematoma produces cytotoxic effects. And this is an area that I've been interested in the past, looking at ways to try to mitigate the production of perihematomal edema, but also ways to look at mitigating the effects of the heme degradation products that we'll talk about. So one of the things that I think, again, for our emergency medicine community is to stress upon them the fact that intracerebral hemorrhages are not a static event. Before the late 1980s and early 1990s, we thought that once you had a hematoma, the volume was fixed, you pretty much had it, and we were done. But Tom Brott and his colleagues, back when the original NINDS trial was being performed, had a side study. And what would happen is they would take patients who they thought would be eligible for the NINDS trial, perform a CT scan on them, find that they had a hemorrhage, but in the follow-up study, for those who had a hemorrhage, we would actually do a CT scan 24 hours later, and what we found was that there was significant growth in those patients. So it reinforced for the first time, or alluded to for the first time, that hematoma growth is not a static event, and that there are significant amounts of hematoma growth that can occur while the patient is under the care of the physician. So what are the prognostic features of intracerebral hemorrhages, and what are some of the therapeutic targets? Well, clearly the largest one, similar to the severity of a stroke with NIH stroke scale, is the volume of the hematoma. So the ICH volume, the presence and volume of interventricular extension, the growth, the presentation, Glasgow Coma Scale, and the infiltratorial location are all prognostic features that are associated with worse outcome. And if you look at those, which ones can we modify? And it really is the growth of the ICH and the resulting volumes of the ICH, as well as any interventricular extension, are the ones that may be biologically modifiable. And as you'll hear about in a little bit, that we're actually looking at some of the cytotoxic effects, like deferoxamine as a way to chelate the iron, as another additional therapeutic intervention for these patients. So Claude Hemphill, back about 20 some years, actually over 20 years ago, came up with the ICH score. And it was a way to try to better understand the prognosis of patients who presented with ICH. And it's still used to this day as part of our Get With the Guidelines and much of our certification programs in the United States. This is a requirement that we actually record the presenting ICH score as a way to understand risk modification, or as a way to start looking at severity adjustments in our prognosis. And so again, presenting GCS, the size of the hemorrhage volume, the presence of interventricular hemorrhage, the presence of infiltratorial origin, and then again age, are all components of this score. And once you get to a score that's 3, 4, or 5, the mortality at that point is almost 80, 90, almost 100%. So it's a nice way to get granular prognosis of a ICH in the patient using fairly easily obtainable elements of the ICH score. The other thing, this is again a picture from Tom Brott back in the day, one of my mentors who was an avid golfer. And what we found was that, even a little bit of hematoma growth goes a long way. So a ping pong ball is roughly 28 mLs or 28 cc's, whereas a golf ball is just 15 mLs larger. So it doesn't seem like that much of a difference in volume, and yet that's a common difference between when the patient presents and then 6, 9, 10 hours later, it's actually grown to the size of a golf ball, which in and of itself doesn't sound like a big deal. But if you look at that influence on mortality, a golf ball size hematoma, again, is associated with a mortality of about 19%. But increasing it to 43, the size of a golf ball, it can almost double the mortality. So there is an inflection point in the outcome versus hematoma volume that occurs in the 30, 40, and 50 range. And so it's really important that if we can come up with a strategy to prevent that growth, then we can actually make an impact on the patient's outcome. And I'll remind people that we were struggling trying to find a simple way to calculate hematoma volume. And Rashmi Katari, actually was his 7th grade son, said, "Dad, it looks like an ellipsoid to me." And he said, "You're right." And so this is where we came up with the ABC/2 way to calculate hematoma volume. And to this day, it remains a very simple, reproducible way of calculating and estimating for most spontaneous ICH the hematoma volume, although with newer software that is becoming online for both acute ischemic stroke and hemorrhagic stroke, new automated detection of the hemorrhage, as well as analysis of the hemorrhage itself in terms of its size, and other features will become available to us in the near term. So when we look at current best management for patients with intracerebral hemorrhage, there are several sources. These are just 2 of the many that are out there. Again, Claude Hempel was the lead author on the American Heart Association guidelines published in 2015. Those are being updated as we speak and will be released in the near term. Also, Thorsten Steiner with ESO has their guidelines, and they're very similar in nature. They came out in the same time frame. So there are nice references that people can look to and towards to get some guidance on how to manage these patients. Well, how do they present? Well, as I tell my residents and I tell my fellows that, despite how good you think you are clinically and how much you think you can distinguish between an ischemic stroke and a hemorrhagic stroke, that you really can't. There are some features and signs and symptoms that are more common in hemorrhagic stroke, such as headache, vomiting, progression of symptoms, but it is something that until you get neuroimaging, you can't fully identify a patient with an intracerebral hemorrhage and distinguish them from an acute ischemic stroke. The important history elements are shown here, and I won't go through all of them, but just like any stroke, time of last known normal or last known well is very important. Not that we currently have a therapy that is time-based, but it is still an important understanding. When we look at the hematoma, we understand the risk of hemorrhage growth depending upon when it occurred. And also it can be a distinguishing feature in determining whether or not we think it's due to a primary cause or a secondary lesion. Obviously, medication use is important, anticoagulants, antiplatelet agents, but also drugs of abuse are important in this, and other features. So you want to get to critical elements of their history and physical that will give you some insights as to why they had it, and perhaps some modifiable conditions such as liver disease, which would produce a coagulopathy that we could intervene upon. So baseline labs, again, these are patients that are identified typically during the evaluation for a stroke alert. So they come into the hospital, we think they're having an acute ischemic stroke. We send off the typical labs that we would do for acute ischemic stroke, which are very similar in the setting of ICH. And then we find that they have a hemorrhage on the CT scan. So the CT scan remains the gold standard because that's typically the first imaging that we find. And it also produces the information such as the location, existing hydrocephalus. There may be already signs of early herniation with this, but then we can do additional imaging. And we've been trying to find ways to utilize the spot sign, for example, for patients at higher risk for hematoma growth. And it can also look for structural issues. And then again, if you have concerns that this is an atypical ICH, either based on age or presentation on the CT scan, then you can do additional imaging such as MRI, MRA, or digital subtraction angiography. Now, who do you do that on? Well, that's a great question. And again, we don't have infinite resources. So this is a nice algorithm that was published just last year by McGurgan and their team. And again, we can begin to think that there may be an underlying vascular abnormality on the non-contrast CT scan when we see things such as the presence of subarachnoid hemorrhage or large vessels with calcifications at the margin of the ICH, unusual hematoma shape. Again, why is it important to know last known well time? Well, if we see edema out of proportion to onset time, it may suggest that there's some underlying structural issue like a tumor that was present prior to the hemorrhage. And again, venous hyperattenuation could be a sign, and again, other masses. And so if you have a typical patient who has a typical location of a non-lobar, thalamic or putamental hemorrhage, and somebody who's got long-standing hypertension, who's older of age, again, it's a deep location, they have CT findings of a lot of small vessel disease, you may not need to progress on to more advanced imaging. However, if you have a younger patient with no history of hypertension at the lobar location, the brain parenchyma otherwise looks great, well, this patient has a higher risk for having some underlying structural issue that needs to be identified. So this is a great way to start triaging the resources that you may need to image patients for some underlying issue with this. ICH management is no different than acute ischemic stroke, although they do present more commonly with issues that need to be addressed when it comes to the ABCs. We do need to protect their airway when it's appropriate. And the reason why I say that is that, yes, we need to protect their airway, but again, intubating patients and having them on a ventilator is associated with a lot of different complications that lead to increased risks of mortality. So we do need to do it when it's necessary, but it shouldn't be done without really thinking about the need for this. Again, addressing blood pressure, and in patients who may present late, we may already find signs of herniation like Cushing's triad. We want to do supportive medical care. These patients often have comorbidities that we need to address concurrently. We want to do some general neurologic specific care, and as I'll touch on here, we want to do some hemorrhagic specific care. And I'll put in a plug again that just like acute ischemic stroke, the one thing that we can do that will benefit all patients with acute intracerebral hemorrhage is that we manage them in the inpatient setting in a stroke unit where we have the nursing care and the protocols in place that will really give them the optimal opportunities for a good outcome. So again, the ABCs are fairly straightforward. We also want to do targeted medical management. We want to be very careful to ensure that they are not hyperthermic. Like ischemic stroke, this is associated with worse outcomes. We want reasonably tight glycemic control. Again, we don't need to get them down to 110. We also want to make sure that we don't produce hypoglycemia iatrogenically, but we do want some glycemic control with this. And we also want to make sure that if we do identify a coagulopathy, that we begin to address and correct that. So I'll get back to my point. What can be fixed? Well, we can try to stop the bleeding. And then we can also look at managing the complications as you'll hear about in Dr. Lee's talk about the space-occupying presence of the hematoma volume that produces midline shift and other disruptions. Later on, we can start thinking about removing the blood, and we still have to decide, is that actually beneficial and what's the best timing for that and the best mode of doing it. We can look at ways to try to reduce the perihematomal edema. And then lastly, we can look at ways to try to mitigate some of the neurotoxicity that develops with the heme degradation that will occur as the hematoma resolves. So for blood pressure management, I won't go into great details. I think Dr. Lee is going to speak to this. We've had several trials, Attach 2 as an example, looking at optimal blood pressure, but currently we feel that it is probably safe to lower the systolic blood pressure acutely in patients who present with hypertension, 150 to 220 systolic, into the 140 range. It's probably safe and probably actually is beneficial. The next thing we need to do is identify and then correct any type of coagulopathy that may be there, either from anticoagulation, antiplatelets, heparin for DVT prophylaxis. There could be a multitude of different reasons why these patients have a coagulopathy. And it's increasingly common as we introduce more therapies for atrial fibrillation, which increase the risk. So starting with patients who are on antiplatelets, again, if you look at the PATCH trial, there was no benefit, and actually there was an increased risk of complications in patients who were routinely given platelets. However, if patients are going to go to surgery or they have underlying thrombocytopenia, that platelet transfusions need to be considered. The threshold for transfusion, again, is going to be up to the local physicians developing the protocol, whether it's 50,000, 100,000, but again, routine use in patients who are not thrombocytopenic of platelets is not indicated. And again, for patients who may be on heparin at the time of their hemorrhage, then we can use protamine in a fairly standard dose to try to address that coagulopathy. Well, up until 15 years ago, we had primarily warfarin as our primary mode of anticoagulation. So as the vitamin K antagonist that it is, when we see patients who present with an elevated INR in the setting of an ICH, we want to try to fix that. And we also, we want to do that by first giving them vitamin K. We can do it slowly intravenously, but we have to be aware that that is not sufficient for reversal in the first few hours when that hematoma growth is going to be at its greatest. Our target locally is an INR of 1.3, and we approach these by using 4-factor prothrombin complex concentrates. In settings that don't have that, you can consider fresh frozen plasma, but again, it takes a much larger volume and it has increased risks of complication. And despite several studies, currently there is no indication for using prothrombotic agents like factor 7A in this patient cohort. We also see that we have other agents that have been used now, the NOACs, for example, the direct thrombin inhibitors and the factor 10A inhibitors for patients with AFib. We're still understanding what's the most appropriate way to manage these patients, and we also have to think of cost. For an example, Indexanet alpha has a charge that's 10 times that of the same dose of 4-factor PCCs. So again, we have Praxibine for dabigatran, or you can use 4-factor PCCs. Patients who have renal disease could be considered for hemodialysis when they're on dabigatran. And again, for the factor 10A inhibitors, 4-factor PCCs is what you probably see most commonly. If people have taken a recent dose within the previous couple of hours, depending upon their airway status and other things, activated charcoal could be considered. But again, you want to make sure you do it in a safe fashion. I'm going to talk about hemostatic management. This was something that I've been working on for some time, involved in the FAST and STOP-IT studies, as well as the Stoplight trial, which was performed in Canada. And to date, factor 7A, despite its ability to decrease hematoma growth, has not been shown to affect clinical outcomes. There is an ongoing study now called FASTIST that is being done through the StrokeNet and is being done globally, looking at ultra-early administration of recombinant factor 7A, both in the emergency department, but also in mobile stroke units. So again, trying to identify the therapeutic window where this may work. Similarly, we see TXA also has been studied and also did not show improved long-term outcomes. However, studies of TXA are also underway in patients also in mobile stroke units, as well as for patients who have a spontaneous ICH on NOACs. There is the TICH NOAC trial looking at TXA as a way to stop the hematoma growth. You'll hear more about surgical recommendations, and again, this is an area of great interest and growth. Since these publications came out, the guidelines in 2015 with the AHA, as well as the ESO guidelines in 2014, we've seen an explosion of interest in stereotactic and other methods of minimally invasive means of surgically evacuating the hematoma with devices and such that you'll hear about. But at the time of the guidelines being written, that the usefulness of surgery for most patients was uncertain. In patients who had an infratentorial location of their hemorrhage with brainstem compression or hydrocephalus, that surgery was indicated. But for patients, also in patients who have lobar clots that are of decent size, greater than 30 cc's, and are just under the cortex, that this may be a target, a surgical target for us. But for other approaches to deeper hemorrhages, we are still looking for definitive clinical trials. There's the MIND trial as an example of one looking at this that will really help guide us, not only in terms of what hemorrhages are most appropriate for surgical evacuation, but also the timing. I'm going to touch briefly on the perihematomal environment. I think this is an area that gets not enough study, but has the potential to help mitigate some of the long-term consequences of this very lethal form of stroke. So the hemorrhage, actually, Ken Wagner, when I was at the University of Cincinnati back in 1980s, 1990s, we had a porcine model looking at this, and it was shown that the hematoma itself not only produces damage by the space-occupying nature of the hematoma, but the degradation products from the hemoxygenase activity on the hemoglobin produced all sorts of evil humors, for lack of better words. And so there are several trials looking at ways to try to mitigate the production of these cytotoxic effectors. The IDEF style study, unfortunately, of deferoxamine as a chelating agent was not shown to be beneficial, but it was safe. The CHARM study is looking at ways to protect the blood-brain barrier, and again, others are also being pursued. Finishing up, inpatient management, again, just like acute ischemic stroke, these patients should be managed in an area that can monitor them. And again, depending upon their severity, it should be either a neurocritical care or an intensive care unit, or at least a stroke floor. And again, where they can be monitored for good glucose control, DVT prophylaxis, both while in the acute phase, also long term. Seizures, I'm going to touch on briefly. It's more common than you think. Paul Vespa at UCLA found that a significant proportion of his patients who were intubated in his ICU were actually having seizure activity. It's more common in lobar presentations, and most will develop seizures within the first 72 hours. There is currently no indication for seizure prophylaxis, but when they do seize, phenytoin, levetiracetam are agents that are commonly used. And the good news is it does not convey lifelong risk of epilepsy. And this is from the guidelines. Again, if you see seizures, treat them. If you don't, but you're concerned, do continuous EEG in patients who are obtunded or have a significant change in mental status that is not commensurate with what you'd see on the CT scan. You should be looking for seizure activity and not prophylactically giving it to them. The other thing is that we have found that it's even though we have the ICH score, it's hard to predict outcome. So aggressive full care should be considered in patients for the first day or two prior to making determinations of DNR establishment. If they come in with a pre-existing one, then you need to honor that. But you need to wait for the first day to let things equilibrate and really try to be able to better predict what kind of outcome these patients will have. So in summary, just like acute ischemic stroke, ICH is an emergency and it should be managed in an appropriate setting like a stroke unit or ICU. We need to focus on immediate physiologic optimization, promptly correct any anticoagulation that we've produced or coagulopathy that the patient may have. You'll hear more about considerations for surgery and monitoring these patients for complications. And if you can't provide that level of care where you're currently practicing, then you need to work and consider transfer to a higher level of care that can. So I want to again thank MENASO and the organizers for this opportunity to participate in this great group of presentations, and hopefully I did not